Greetings, my name is Georg Wiese, and I'll be presenting our study, Components of High-Resolution Manometry That Change Surgical Decisions. I'd like to thank the SAGES committee for inviting me to speak on this topic. I'd also like to thank the attendees who are in the audience around the country and the world. Finally, I'd like to thank my co-authors who are listed below, and most of all, Dr. Steve Eubanks, who is my mentor and has worked with me throughout my fellowship and on this study itself. My disclosures are listed below. I did work as a consultant for Transenterics, and I received a consulting fee for that service. So SAGES has previously produced guidelines in 2010 for gastroesophageal reflux disease and 2011 for achalasia regarding preoperative workup. These included EGD, pH studies, manometry, upper GI, and in some cases gastric emptying studies for GERD, with an emphasis as well on confirmation of diagnosis of GERD prior to surgery. For achalasia, this preoperative workup included EGD, upper GIs, and manometry. Once again, confirmation of the diagnosis of achalasia was paramount prior to surgery. Common to both of these is manometry. Well, what is manometry and what is high-resolution manometry? Manometry is a means of evaluating pressure differentials and patterns of peristalsis along the length of the esophagus. High-resolution manometry was first appeared in the 2000s and was an improvement on prior esophageal pressure topography graphs, which were much like EEGs. And a representation of this can be seen to the right on the slide. HRM provided graphic representation of data, led to easier methods of reading and interpreting these results, and a quicker clinical application. The Chicago classification system, now in its third iteration, most recently updated in 2014, was a means to organize and interpret this high-resolution manometry. Our study wanted to find out what about high-resolution manometry changes surgical decisions. We previously reported that findings on HRM have changed our surgical decisions in as much as 51% of cases. Alterations included choices of fundoplication, complete versus partial, a need for a myotomy or esophagectomy, or even the decision to avoid surgery altogether. The purpose of this study was to look at what specific aspects of high-resolution manometry, as reported by the Chicago classification system, carried the most influence on these surgical decisions. Our methods included looking at all of our HRM studies between 2012 and 2016. We excluded any patients who were not seen by a surgeon, and we collected data on all preoperative symptoms, upper GIs, pH studies, EGDs, biopsy reports, and of course the manometry reports. A single surgeon blinded to patient identity and without knowledge of the manometry results then decided on the most appropriate procedure. The surgeon was then exposed to the high-resolution manometry results, and the procedural plans were revised, and this data was recorded. HRM results were then evaluated to determine which factors most influence surgical decisions. Now, for our purposes, we defined abnormal motility in our study as anything other than normal. These included achalasia, outflow obstruction, motility disorders, or peristalsis abnormalities. And distal contractile integral was a measure of the strength of the contraction of the esophagus, and this number correlated with amplitude times duration times length of the distal esophageal contractions greater than 20 millimeters of mercury from the proximal to distal pressure trough seen in the manometry graphic. Here's a breakdown of our patient demographics. A total of 298 high-resolution manometry results were identified. 114 of these met our search criteria and were reviewed by a single surgeon. This is a quick synopsis of our data, and I will go into all the areas with boxes around them in our next graph. Overall, in 50.9% of cases, high-resolution manometry was found to have altered the planned procedure. Abnormal motility was identified by Chicago classification in 54% of cases, and this corresponded to 72% of the patients in which HRM changed surgical decision. A DCI of less than 1,000 was identified in only 31.6% of patients, but 39.7% of cases where the surgical decision was altered. And a DCI of less than 1,500 was identified in 49% of patients, but 55% of those where the surgical decision was altered. Our data indicate that abnormal motility identified by the Chicago classification system was a deciding factor on altering surgical plans 72.4% of the time. Weak peristalsis was the next important factor, with 39.7% of patients with DCI less than 1,000, or 55% of those with DCI less than 1,500, affecting our surgical decision. It is notable that in the setting of normal motility, in 27.6% of cases where HRM results still altered surgical plans, this often correlated with the weaker contractility, or DCI less than 1,500. And when this was in the normal range with a normal DCI, it was often correlated with a paraesophageal hernia or incomplete bolus clearance. So controversy exists regarding tailoring one's approach to surgery at the GE junction, and specifically how high-resolution manometry can affect this decision. This retrospective single-institution and blinded study demonstrates the value of identifying abnormal motility by high-resolution manometry and the Chicago classification system, and its effect on surgical decision-making at the GE junction. Furthermore, it identifies that additional factors, such as low DCI, can have significant influence on surgical choice. We are currently investigating an expanded patient population and multiple providers at different institutions to continue to validate these findings and move on to the next step of this research. Thank you very much for allowing me to present this data to you. If you have any questions or comments, please contact me and my information below. Once again, thank you for your time and attendance.